We live in exciting times. We had the first landmark study with a PCSK9 inhibitor taking LDL levels down to levels that we would never have imagined, even say 7-8 years ago. But not only one trial, a second trial with bocosuzumab, which was, at least INSPIRE 2, was overall really consistent with the results of FOURIER and evolocumab. So would you like to comment on your perception of those findings, and how would you anticipate that they might affect clinical practice in very high-risk patients in the United States?
Sure. I think, as you said, it is very exciting. Although among the experts and our little clique of friends, there may have been some disappointment and some criticism because the trials were short. But I think they showed us once again that LDL lowering works, that it doesn't have to be a statin, that within the realm of these relatively short trials of about 2 years, each of those that you just mentioned, where the results are expected based on the CTT regression line. So what does that mean to the clinician? I think I can maybe put this into several groups of physicians. There are physicians who for many years have felt the statins were magical and work well beyond or completely independently of their LDL lowering. And when IMPROVE-IT came along, there was that first non-statin drug. It convinced many people, but maybe not everybody, because it was a modest, although expected, reduction in events. Now we have the PCSK9 drugs. And so I think physicians, cardiologists in particular, will be very eager to lower their patients' LDLs. And of course, in the United States, the eagerness of the physician is facing the lack of enthusiasm by the payers. And so how do we deal with this? And who are the patients that we want to treat most, and who are the patients where we have to, will meet resistance? And I think, first of all, everyone has to be on a statin unless you can prove they're statin intolerant. And above that, I think everybody should be on ezetimibe. It's been proven now in a study, and it was proven under really rigorous conditions of 50 plus or minus a little bit better than 70. And so when you have a patient on those drugs, if their LDL is still over 100 milligrams per deciliter, that means they started at 200 or more. Many of them will have FH or severe polygenic hypercholesterolemia. And I think this new treatment will bring them down from, if they're between 100 and 120, they'll be down at 30 to 50 to 60. Putting that on the regression line from the IVUS trials are just simply the results of the Glagoff trial. We should have no further progression in the vast majority of those people, or even regression.